Hello, and welcome to the Transplant Treatment Journey webinar presented by the National Bone-Marrow Transplant link. At this time, all participants are in a listen-only mode. You may ask a question at any time by typing it into the Ask a Question feature on the left side of your screen. If anyone dialed in to require operator assistance, please press *0 on your telephone keypad. As a reminder, this conference is being recorded. It is now my pleasure to introduce your host, Jennifer Gillette. Please go ahead.
Thank you, Kevin, and thank you to all who came today. Hello and welcome. My name is, again, Jennifer Gillette, and I'm the staff social worker at the National Bone-Marrow Transplant link. Just so you know, today's presentation, all the copies of the slides will be available after we're done. I'd like to give you a basic outline of what today's program is going to look like. Let me see, forgive me, I'm just clicking it on there for you. So first we're going to start out with a basic introduction to the link, and just for those who are maybe not familiar with us, and then we'll have an overview of the transplant process, which will last about 15 minutes. Then we'll spend about another 15 minutes learning about clinical trials, and then we'll spend about 10 minutes learning about coping strategies. And then we will open the floor to questions. Before we hear from our speakers, I'd like to take a moment to tell you about your provider for this event, the National Bone-Marrow Transplant link. NBNT link is dedicated to helping individuals and their families from diagnosis through survivorship. We work with hospitals, cancer centers, and other organizations to reinforce, complement medical care by providing resources, support, and education. If anyone is needing more support from us, you can reach out to the phone number on this slide, or you're also welcome to email either Peggy Burkhart or myself, Jennifer Gillette. We also provide resources to help families navigate the transplant journey. We have our chronic graft-versus-host disease telephone series and webinar support. We have lunch and learn programs. We have multiple webinars that have been recorded on our website that you can go on. We have our peer support mentor program for patients and caregivers. These are people that have been through the process that can be there to guide you. And then our second birthdays recognition program, and of course a variety of resource books, materials, and referrals. A special thanks to our webinar event sponsors, the National Marrow Donor Program, Be the Match, the Leukemia and Lymphoma Society, Jazz Pharmaceuticals, Gilead Sciences, the Karmanos Cancer Center's Blood and Marrow Stem Cell Transplant Program, and of course our esteemed link partners for their continued support and all that we do. Today's presentation is meant to inform and support. It's not intended to replace individualized medical advice. Before adding any new approach or treatment to your regimen, you should discuss this with your healthcare provider to determine if that intervention is right for you. Now, without further ado, I'd like to introduce you to our first speaker, Stacy Preer, the Transplant Coordinator of Blood and Marrow Stem Cell Transplant Program at Karmanos Cancer Center. Stacy received her nursing degree at the University of Windsor. She has been a bone marrow transplant nurse since 1991 and became a transplant coordinator for the Karmanos Cancer Center's Blood and Marrow Stem Cell Transplant Program in 2001. Stacy specializes in coordinating both allogeneic and unrelated transplants. She achieved her certified hematopoietic transplant coordinator status in 2005 and was on the certification committee for 4 years, acting as both a vice chair and chair during that period. She's worked closely with the NMDP and has been a speaker and part of their council meetings and coordinator events. Thank you, Stacy, for joining us today.
Thank you. So my name is Stacy Preer, and I'm just going to talk to you a little bit about an overview about blood and marrow stem cell transplant. So I work at Karmanos Cancer Center in downtown Detroit, and I've been here my whole career. And what is a hematopoietic stem cell? So basically, it's the most mature form of the body's blood cell. And how I like to describe it to patients is this cell has not decided what it wants to become when it grows up. So it can become a white blood cell, a red blood cell, a platelet. And these little stem cells are made in our bone marrow, and they're very sensitive to chemo and radiation, which allows, because of the initiative of stem cell transplant, we're able to give higher doses of chemotherapy, knowing it's going to wipe out the bone marrow, but then we can replace it with either the patient's own stem cells or someone else's stem cells. This is a little picture of the hematopoietic stem cell and just how it can divide into the different cells. So a little history on bone marrow transplant. In the 19th century, they realized that the bone marrow is what actually created the blood cells, the white blood cells, the red blood cells, the platelets, etc. So then they thought that, well, maybe someone with leukemia who has a disease in their bone marrow could be treated by giving them someone else's healthy stem cells or bone marrow. And they actually started treating anemia by injecting bone marrow cells into the sternum or the breastplate. So, and then the atomic bomb happened, and it was discovered that stem cells are very sensitive to irradiation or radiation. The first transplant was in the 1950s, and then in the 1960s we discovered the HLA system. I'm going to talk more about what HLA is further on in the slides, but that was a very important discovery on the success of bone marrow transplants. They also made a lot of advancements, such as the discovery of cyclosporin. Now, here at Karmanos, we don't use cyclosporin as an anti-graft-versus-host, anti-rejection drug anymore. We use a different drug that has the same properties called tacrolimus. But cyclosporin was very important because it helped prevent rejection and helped prevent graft-versus-host disease when a patient receives someone else's stem cells. So there are many types of transplant. The first type is an autologous transplant, which is basically the patient is collecting their own stem cells. These stem cells are frozen. Then the patient is treated with either chemo or chemo and radiation. The amount of chemo and radiation that they are given actually destroys their own bone marrow, and then they get their own stem cells back so that their bone marrow gets repopulated with their own stem cells. And that's called an autologous transplant. The next transplant is an HLA perfect match transplant from a family member, such as a sibling. That's called a related allogeneic transplant. The third one is a unrelated donor transplant, and it can be either a matched or a mismatched, and that is, we call it here a MUD, a matched unrelated donor. Then there's an identical twin matched transplant, which is called a syngeneic. In that one, it's kind of unique because if you have an identical twin, your body actually sees it like an autologous transplant. So there's, no chance of or very unlikely that the patient would get graft-versus-host disease, because even though it's from the sibling, they're identical and with identical DNA. And lastly is the haplo-identical transplant, which is a half-match transplant. With a half-match transplant, you can use a mother, a father, a half-match sibling, a child, and the HLA typing is only matched halfway, so a 4 out of 8, or if your center looks at 10 markers, a 5 out of 10. So I'm going to go into a little bit more depth about the autologous transplant. So like I said, the cells are collected in advance, frozen and stored, and the goal is that we can then give the patient higher doses of radiation and chemo, and it's basically a rescue transplant. When we give them back their own cells, it's rescuing them because we've damaged their bone marrow with the high doses of radiation and chemo, and then the patient gets their own stem cells back. The recovery of this is a lot shorter, quicker than if a patient receives someone else's cells. They also will not get graft-versus-host disease because this is their own stem cells, their own DNA. Types of diseases that we treat this way are multiple myeloma, lymphomas, either Hodgkin's disease or non-Hodgkin's lymphoma. Those are diseases that we currently treat with an autologous transplant. Here's a little diagram. So the patient has their stem cells collected. There's 2 ways they can do that, and here at Karmanos we do it the peripheral way. We collect stem cells. So the patient goes on a machine that's very similar to a dialysis machine, except this machine collects stem cells. The other way is the old-fashioned way, which is called a bone marrow harvest, where the patient would go to the OR, they'd be put to sleep, and a doctor would be on either side of their hips and extract the marrow from their iliac crest, which is the back of the hip. We don't do it that way at Karmanos unless the patient failed the stem cell collection. Then we would go to trying a bone marrow harvest. These cells are then treated with a chemical that doesn't harm the cells but keeps the cells viable, and they are frozen in a special freezer, and then a plan is put in place to bring the patient in for the transplant. They get their chemo and radiation, or just chemo depending on their regimen, and then they're given their own stem cells back. I'm going to show you some pictures. So this is a frozen bag of stem cells in the patient's room. It is quickly thawed. This is how we do it here at Karmanos. It is quickly thawed out in the room, and then it is drawn up in great big syringes, and then it is infused into a central venous catheter, whether it's a PICC line or a Hickman or a Groshong. Here we use a double lumen or a triple lumen central venous catheter. And so there you can see the stem cells being pushed into an IV line right into the patient's catheter. Now I'm going to talk a little bit about the related allogeneic transplant. So in a related allogeneic transplant, the donor is usually a brother or a sister, and they're HLA matched. The donor actually goes through the same process that a patient would go through to collect their stem cells. The donor would be put on an apheresis machine, and their stem cells would be collected. Again, the old-fashioned way, we would take the donor to the OR, put the donor to sleep, and extract their marrow that way. So here at Karmanos, we almost always do it the peripheral way for our donors, putting them on the apheresis machine. There is one diagnosis that here at Karmanos we prefer to use marrow, and that is if the patient has aplastic anemia. They have found with research those patients do better if their donor donates marrow versus stem cells. So what we're looking at is on the 6th chromosome of every cell of the body, there's something called the HLA, which is the human leukocyte antigen, and we inherit these from our mom and dad. Unlike blood type, in blood type there's just A, B, O, and AB. In HLA there's thousands and thousands of combinations. So it is DNA testing, and that is what we're using to determine if the patient and the donor match. In an unrelated allogeneic transplant, so if the patient doesn't have a matched family member, then we look at the registry. At Karmanos, we go through the National Marrow Donor Program and search for a donor through the registry. There's more than 22 million donors on this registry, and they're able to access donors around the world. So not every country in the world has donors, but the National Marrow Donor Program can access all the countries that currently have donors and participate in the process of sharing their donors worldwide. Sorry, I think I just went on the wrong slide, so excuse me for 1 second. There we go. So a mismatch allogeneic transplant is when we cannot find a perfect match donor, and we go with a donor that's slightly mismatched. So here at Karmanos, we do what we call 7 out of 8, so one marker doesn't match. We also have done 6 out of 8 and 5 out of 8. The National Marrow Donor Program, we have a study with them, a protocol that we try to put our patients on if the donor is not a perfect match. And so we actually recently did a patient, and his unrelated donor was a 5 out of 8 match. Of course, when the donor does not match the patient perfectly, there's higher risk of complications such as graft-versus-host disease, which I'm going to go into in more detail coming up. And the haploidentical transplant. So not all centers are doing haploidentical transplants, but we are here at Karmanos. We are using half-matched siblings, half-matched parents, half-matched children, and there is, again, a greater risk of complications such as rejection and graft-versus-host disease. So there's some special things we do when we do a haplotransplant. We give extra medication to help prevent rejection and graft-versus-host disease. We also do a special screen on the patient to make sure they don't have antibodies against the mismatches, which helps to prevent rejection. Here's a little diagram of an allogeneic transplant. So you have the patient, and the donor is the one that gets the stem cells harvested either on an apheresis machine or through going to the OR and having their bone marrow harvested. We actually do this simultaneously. So the patient actually gets their high-dose chemotherapy or chemotherapy and radiation, and the day they need the transplant is the day the donor collects their cells to give to the patient. We do it fresh. You can freeze the donor's cells and give them back to the patient at a later date, just like we freeze the cells for a patient getting an autologous transplant, but we do here at Karmanos prefer to do it fresh if we can. Here's a little bit more about the HLA. So you inherit these markers from your mom and dad. So when mom and dad, because there's 2 strands of DNA, mom has 2 and dad has 2, when they have a child, there's 4 different combinations that can occur. So what we tell our patients is, you have 5 siblings, but each sibling only has a 1 in 4 chance of matching. So each sibling has a 25% chance of matching because there's 4 combinations. And I'm going to show you a little diagram. So that's a little diagram of just kind of showing you that dad has 2 haplotypes, mom has 2 haplotypes. So dad can give A and mom can give C. Dad can give A and mom can give D. Dad can give B and mom can give C, or dad can give B and mom can give D. So as you can see, there's 4 combinations, and so sometimes patients have bad luck and they have 5 siblings and nobody matches. The siblings some of them could match each other, but unfortunately no one matches the patient, just bad luck. I like to tell my patients that it's like a die that has 4 sides, and then when you roll it, it could be combination 1, 2, 3, or 4. And what do HLA antigens do? Well, it's basically a blueprint of our immune system, and it's how we recognize self from non-self. So when a patient gets someone else's stem cells, the patient's body is smart and recognizes that these are not part of the patient, but also the cells are smart and realize they're in a foreign body. They're in the patient's body. So when someone has a kidney transplant, their body wants to reject the kidney. That's host versus graft disease. It's opposite in transplant. It's the new cells wanting to reject the patient, which is graft versus host disease. So the new cells are the graft, the patient's the host, and it's the new cells attacking the patient. And that is one of the most serious complications from transplant and what we try to prevent. So I've kind of gone into sources of stem cells already, but just in a little more detail. So we can get stem cells through the bone marrow under anesthesia, where a needle is put in and the marrow is aspirated. Pain is a side effect of this because, of course, they're drilling into the back of the hips. So we tell donors or patients that go through a bone marrow harvest that they're going to be sore for a few days. It could have some bruising and tenderness. And that is not, at our center, not the preferred way to get bone marrow these days. Oops, sorry about that. The other way is the peripheral blood, which is what I talked about. The patient goes on the apheresis machine. So the patient, if they're harvesting their own stem cells, or the donor that is harvesting their cells for a patient, would go on a medication. Here at Karmanos, we use a medication called Zarzio. The National Marrow Donor Program uses a medication called Neupogen. They're both colony-stimulating factors, just made by a different company, so they have different name. And this colony-stimulating factor causes your body to make extra stem cells, so that when your stem cells are collected, you're not depleted of anything. Their patient that's collecting their own stem cells, or a donor that's collecting for a patient, is on this medication for 5 days. And on the 5th day, they go on the apheresis machine, and their stem cells are collected. And that procedure can take about 4 to 6 hours to collect the stem cells. So the lastly is an umbilical cord blood. So a baby's umbilical cord is very rich and full of stem cells. However, there's not a lot of stem cells in the cord. So stem cell transplant is very good for children because they're small and they don't. Your requirement for how many stem cells you need is based on your weight. So a lot of hospitals that transplant children will use the umbilical cord as a source of stem cells, but here at Karmanos we do not. We find that the cord blood units are too small. Some centers are doing double cord transplant, so they actually take 2 umbilical cords and infuse all the stem cells from 2 umbilical cords into the patient, and they're doing that at some centers. We here at Karmanos rarely do cord. It's not that we haven't done them, but we rarely do cord blood transplants. So disease that can be treated with bone marrow transplant, like I said, leukemia, lymphoma, multiple myeloma, any cancers that affect the bone marrow are candidates for bone marrow transplant. We also do aplastic anemia, sickle cell anemia, myelodysplastic syndrome, and myelodysplastic syndrome is a precursor to leukemia, so they're not leukemic yet, but they can become leukemic. And so that is a disease that we do a lot here at Karmanos. There's another disease called myelofibrosis, which is in the same category as myelodysplastic syndrome, and that disease too, untreated, can progress to leukemia. So what determines the type of transplant that you need? So when patients go to the transplant center for their first consultation, the doctor will tell them what type of transplant they're eligible for. Anyone with any type of leukemia, myelodysplastic syndrome, myelofibrosis, because their disease is actually in their bone marrow, they cannot have an autologous transplant. They cannot collect their own stem cells because they'd just be giving themselves back the blood cancer. So they would need an allogeneic transplant, either from a related family member or an unrelated donor. Autologous transplants are for people that have multiple myeloma, Hodgkin's disease, non-Hodgkin's disease. And then, we also look at the health of the patient, the age of the patient. Is their disease in remission? Is their disease progressing? What is their general health? What is the availability of a donor? So we don't have a magic age cutoff here at Karmanos. The oldest patient that I have brought to transplant with a mismatched, unrelated donor was 80 years old. So we have come a long way. People's health is better as we're aging, so there's no magic number. Here at Karmanos, we don't do anyone under the age of 18. If they're under the age of 18, then they would go to Children's Hospital of Michigan. We do 18 and older. So I think my slides got a little mixed up. I'm just going to go back to the slide I was on. They've kind of flip-flopped, so sorry about that. Okay, so the preparative regimen, whether it's for a patient receiving their own stem cells or someone else's stem cells, they have to have a preparative regimen. It's either chemo or chemo and radiation. Currently here at Karmanos, we do not have any regimens that are radiation alone. They're either chemo, different types of chemo, or chemo and radiation. And the patient is given that medication so that it destroys their bone marrow, destroys their stem cells, excuse me, and it can either be myeloablative or reduced intensity. You might have heard a word called a mini transplant. We do not do mini transplants. Both our regimens, whether it's myeloablative or reduced intensity, the patient's bone marrow is going to be knocked out. Their bone marrow is not going to come back unless they receive either their own stem cells back or someone else's. What reduced intensity means is that we just back off on the chemo a little bit to help preserve organ functioning. So if we have someone who maybe had a heart attack or someone who is a smoker and has bad lungs, we would want to use a reduced intensity regimen, which is a little more protective of their organs. If someone has good organ functioning, is young, we want to give them the biggest bang for their buck. We want to give them the highest amount of chemo and radiation we can give them, so we would give them the myeloablative transplant. So every patient is unique and different, and we do a bunch of tests to determine which regimen they can receive. And now I'm just going to talk about some complications of transplant. So some early complications of transplant, of course, we're knocking out the patient's immune system. We're knocking out their bone marrow, so they're at risk for infection. And people that have received chemo and radiation can get pneumonia. They can get a bacteria infection, a viral infection. So infection is a possible complication. Bleeding, because we've knocked out their bone marrow, we've knocked out their platelets. So if they blow their nose, if they cut themselves, they'll have trouble clotting and they can have bleeding. Organ toxicity, any chemo or radiation can cause any organ of the body to be damaged. Unfortunately, the chemo and radiation is meant to knock out the cancer, but can also affect the organ. So we do a lot of organ testing before transplant so that we have a baseline. And then we know if the patient starts experiencing any type of organ dysfunction, we can look back and say, oh, this is their baseline, so they must be experiencing some toxicity due to the chemo or the radiation. Nausea, vomiting, and diarrhea, just like any chemo and radiation, those are possible complications, and there's lots of good medication out there to treat nausea, vomiting, and diarrhea. Hair loss. We tell our patients to be prepared that they're going to lose their hair. Their hair is going to grow back. We like to make a joke and tell them that their hair is going to grow back curly and orange, which some people believe for a minute until we laugh and tell them we're joking. But their hair actually can come back a different color, different texture. We've had people say, well, my hair was curly, now it's straight. It's darker, it's lighter. The hair can be different than it was before, but it will grow back. Unfortunately, if the patient was bald, their hair is not going to grow back where they were bald. They're going to stay bald. Or they're going to not have hair where they didn't have hair. They're not going to have hair where they didn't have hair before. Graft-versus-Host Disease. So graft-versus-Host Disease is only in a transplant where you're getting cells from someone else. You're not going to get graft-versus-host disease if you get your own cells back. And so this only occurs with either a related allogeneic or an unrelated allogeneic or a haploidentical transplant. And it can affect the skin, liver, and the GI tract. We call it acute if it happens within the first 100 days post-transplant. So day of transplant is day 0, and then anything past that is like day +1. So if it happens within the first 100 days, we call it acute, and we treat it with different medications, sometimes steroids, and this can be a higher complication in older patients and if the match isn't a perfect match. And then I have one slide about long-term complications, which are there's some similarities to the short-term. So chronic graft-versus-host disease can occur any day and any time after the first 100 days, and we call it chronic. And it can be a little trickier to treat, a little harder to treat. Infection, so you can still get infections a while after transplant just because your immune system is new. I like to tell my patients that your immune system is like a newborn baby's immune system. So we actually give our patients vaccines anywhere from about 3 months to 6 months after transplant. They'll get all their baby vaccines again, because when we give them the chemo and radiation to wipe out their immune system, we also wipe out their immunity to, you know, all the childhood diseases. So we actually revaccinate them. Cataracts is a long-term effect of the chemotherapy and radiation. Sterility, we tell our patients, we have had patients father children and give birth after transplant, but it is rare. The chemotherapy and the radiation is very high, and it's very likely that they're going to be sterile after transplant. So some patients, if they have the luxury of time, will harvest their eggs or their sperm prior to starting their chemotherapy and radiation. In adults, we don't really worry about the growth retardation. That's more in children. Chemotherapy and radiation can cause stunting of growth. And of course, the relapse of the original disease. So our goal and our hope is that we're going to cure the cancer. It's never going to come back, but their disease could come back. So that's another possible complication. It's not a complication of the bone marrow transplant, it's just that their disease was very aggressive and came back. So that is it for my slides.
Thank you so much, Stacy. We really appreciate you presenting with us today. That was very informative. And I know that just for the sake of time, we will keep questions to the end, but I do see them coming in, so be prepared. Next in our presentation today, we have Scott Kerwin, who is the director of the Jason Carter Clinical Trials Program from the National Marrow Donor Program and Be the Match. Scott is a registered nurse with experience in critical care, solid organ transplantation, and oncology clinical research. He received his bachelor's in biomedical engineering at Marquette University and completed a Master of Nursing program at the University of Minnesota. With over 20 years of experience in the medical device field and hospital-based care, he has thorough understanding of clinical research and has worked closely with patients, investigators, and industry through all steps in the clinical trial process. He now leads the Jason Carter Clinical Trials Program at Be the Match, which is dedicated to bring clinical trial options for patients with blood cancers and blood disorders throughout the U.S. Thank you so much for joining us, Scott.
Thank you very much, Jen. So we'll get started. Basically, I'm just going to talk about clinical trials, give you the basics, the understanding of how the clinical trials work and what they are, and we'll touch also about clinical trials related to transplant and immunotherapy. So just starting at the front end, we'll define what clinical trials are. They are research studies that explore whether a medical procedure, therapy, or device is safe and effective to treat a specific condition or disease in humans. They're the only vehicle for a new drug or immunotherapy or medical device to gain FDA approval. So that's why they're so important for us advancing the science of the medical treatments. So for many people, they do provide the only chance of getting treatment after exhausting all standard therapies. Unfortunately, fewer than 10% of patients with cancer participate in clinical trials, and only 20% of patients say their physician had discussed clinical trials as an option for them. And it's important to realize that overall survival rates for some cancers are significantly higher for patients that are involved in clinical trials versus those who do not. So there's two basic types of clinical trials that I'm going to talk about today. The first one is called observational clinical trial, and this is where, with your consent, the doctors and researchers will collect your medical data as you're getting standard care treatments for your illness. So there's nothing necessarily experimental about the treatment you're getting, but they are taking your data and they'll follow you over time, and they use that data to see if they can find a relationship between either the treatments that you received or the demographics about you or your other history about you that can impact your outcome. So it's mostly data gathering and then applying different algorithms to see what factors are important in treating cancer. The other type of trial that we're going to talk more about is interventional, and this is where something is new, something is different than standard care, be it a drug or a procedure or a dose of drug is different. Now, the interventional trials are really broken up into 4 different phases. So the earlier or newer a drug or a treatment is, it's going to be in the earlier phases. So the phase 1 trial is designed really to test the safety of a new therapy. Before it even gets into a phase 1 trial, many drugs are started off in the lab, so they're doing experiments and using different devices to monitor the chemical reactions that these different drugs might have on cells. And then once they get further, they move into animal testing, and so they'll use them on mice. And then once they feel confident about the next step, they'll start a phase 1 clinical trial. These are usually small groups of patients, and they're typically not used for people that have newly diagnosed disease, but are people that have maybe already tried standard therapies and that did not work for them. And an example would be a new drug that treats relapsed ALL, and it's given at different doses. So they'll give first patient the dose at 5 milligrams every day, and then the next patient 10, etc. And what they want to do is to give the highest dose they can that the patient can tolerate, so there aren't harmful side effects. Stacy kind of alluded to this before about how we want to get as much bang for the buck when we have a drug put into the system so that it can have the best chance of finding and killing the cancer. And that's what phase 1 trials are typically about. After phase 1, if they do well, they go to a phase 2 trial. This is a larger group, and this is where they're trying to see, does it do what they want it to do? So it's, if you have a new drug, you want to see if it's going to be able to kill the leukemia cells or the lymphoma. And so that's the kind of focus. They're always looking at safety because that's the most important part. But this one is now, is it working? And so this is another example where we have a drug called Nivolumab to treat multiple myeloma. Nivolumab is an FDA-approved drug already, so it's not as experimental as other things are. But it's only approved to treat Hodgkin lymphoma, and so treating myeloma with it is completely different. So it has to go through this process in order to be approved for that indication. If phase 2 goes well, then we go to phase 3, and this is kind of the big one. So this is where they have many hundreds of patients most of the time. They use things called randomization and blinding, and many times they'll use placebos, and we'll talk about that in a little bit. So the part of using a placebo and randomization is really about getting the bias out of the study so that they can really focus in on the specific difference in one treatment versus a standard treatment. An example here is using a new drug called itacitinib with steroids to treat graft-versus-host disease. Many times the normal prescription is to give steroids. So in this kind of a trial, a person would be randomized to either get the new drug plus steroids or just the steroids and then a placebo, a pill with no medicine in it. And they wouldn't necessarily know, they shouldn't know which they're getting until the end of the trial. So that can be kind of off-putting to some people when they're joining a trial, not knowing what they're getting, but we'll talk about that in a little bit. And then the fourth phase is really mostly about surveillance. So the trial would be, the drug would be approved after phase 3 by the FDA, but the FDA wants to make sure there aren't long-term issues with it. So 5 years after taking a drug that they find out that people have complications, or maybe it induces a different disease. So that's why they're still monitored under a clinical trial, but they're already approved once they're in the phase 4. And now we'll talk a little bit about informed consent. Informed consent is a formal process that is used to ensure that you understand what you're getting involved in when you join a clinical trial. So during this process, either the doctor or a study coordinator will sit down with you. They'll walk you through a pretty lengthy document, and it'll go through what the purpose of the trial is, what kind of procedures or tests will be happening during the trial, and they want to go over the possible risks and possible benefits. And they also want to talk about other treatments, options that you have instead of being in the trial. It's not about trying to say you have to do this trial or nothing. It's saying, well, you could do standard care, but here's a trial, and let's see if you might be interested in it. They'll also talk about your rights as a participant in the trial, and even though you're going to be signing this to show that you're consenting, and the doctor would sign it as well, it is not in any way a legal document. You would have not in any legal obligation to do anything. And so that's important to remember. It feels pretty intimidating, or it can feel intimidating, but you still have all the rights that you would have before signing an informed consent form. So during the process, be sure to ask as many questions as you think of related to the trial, but also know that you can ask them later and you can inquire, and if you suddenly realize there's something in the trial that you really didn't understand before, and now you don't want to do it, you always know, and I'll reiterate this later, you always can leave the trial. So it's not something that you have to worry about. Do talk to your regular doctor about the trial, your friends and family. It's important that you get as many perspectives as you can. But again, being in a trial is always voluntarily. You may or may not get any benefit from being in the trial. And if you join a trial, as I said many times, you can quit at any time. And if you do quit, it's not going to affect the quality of your care. You're not going to be kicked out of the hospital, or no one's going to be angry with you. It's a perfectly understandable thing that people leave trials. So a couple of common misconceptions about trials, and I think we've talked about a lot of these already, is about people get fear of not getting any medicine at all. They just get placebo. And that does not happen. If you have a disease and there's a normal standard treatment for that disease, you will not be in a trial where all you got was a pill with no medicine in it. Because, of course, that's unethical, and it just wouldn't be a humane thing to do. And then we already talked about being stuck in a trial because you signed the forms, and of course you're not. And we're not worried about doctors being angry or not getting treatment if you were to quit a trial. Another interesting one is people might feel like they're a guinea pig, or they're like a science experiment, and they're not being treated as a person. And what I've found, and many people have said this as well, is that if you're in a trial, you have almost two care teams. You have a lot of the standard care team people, like other doctors and nurses that care for you, and you have the research team looking out for you. You get a lot more treatment. You're almost like a VIP, in my opinion, once you're in a clinical trial. And many people think that clinical trials are very dangerous and risky. And again, there are so many steps taken to get to a point where there's a clinical trial. A lot of that danger and risk is minimized. Now, of course, there is risk. There's risk in every treatment. But to say that it's very dangerous and risky is a little bit of an exaggeration. So a lot of the questions that I get when I talk with patients about trials are really about, I just learned I have a new diagnosis of this, or I've relapsed 3 times and I don't have any more options. What kind of trials are available for me? It's a challenge for people to find trials on their own if their doctor isn't able to point them in the right direction. So I'm going to talk a little bit about our program, which is trying to alleviate that. They also ask about the placebos, of course, and will they be blinded, meaning will they know what the treatment is, or will they have to wait until after the treatment is over to know what the treatment is? There are questions about insurance. So the general rule for clinical trials is if you are in a trial, the part that is experimental, if it's a drug or a new surgery or something else, the part that's experimental would typically be paid for by the sponsor or the company that's trying to develop the drug, or maybe the hospital. And then the part that's standard, the part that you would have care for whether or not you're in the trial, would be billed to your insurance. So that's the typical way that it works, but it's always good to check with your insurance or have your hospital check with the insurance to make sure there's no surprises. And then let's see. Again, they ask, of course, what happens if I want to leave a trial and the impact that has. So some of the clinical trials, there's of course hundreds of clinical trials in the U.S., but some of them for transplant in particular, and Stacy talked about haploidentical, is that haploidentical is getting more and more common. So the reason why it's getting more common is many people who don't have a match on a registry or a perfect match from a sibling are saying, well, what are my options? And so now that you can have a match that's a half match, that opens up quite a few more options for people. Every parent is a half match for their child and vice versa. So now you have a lot bigger pool. Now the risks are bigger, again, as Stacy mentioned, with more complications. And so a lot of the trials are trying to really fine-tune the preparative regimen and post-care so that they can make haploidentical transplants as safe as fully matched transplants. Right now, I think there are over 90 trials in the U.S. related to haploidentical transplants. Many also are looking at, of course, graft-versus-host disease. both to prevent it from coming at all or to treat it once it's there. It's one of the biggest complications and the most life-threatening, and really affects quality of life. And so there are a lot of that are trying to develop those drugs to make that better, or again on the preparative side to prevent it from coming. There are also many different diseases that mostly about when we have diseases of the immune system that transplant is starting to be used for. So things like Crohn's disease, multiple sclerosis, systemic scleroderma, and are being treated with transplant for the first time and seeing some interesting results. These wouldn't normally be done because there is that risk of transplant versus the risk of the disease that they're be treating. But now that we're getting more and more sophisticated and transplants are getting safer and safer, they're willing to take that risk and reward balance and say that we should treat that. Sickle cell disease has been treated with transplant in the U.S. for some time, but only for children, and only for children that have it severe. And they typically want it to be a perfect match. So there are many trials still for adults for sickle cell, but it's not yet quite in standard of care yet. So hopefully that will be something that is happening sooner, and can we expand sickle cell treatment with transplant. And then the last one there is gene therapy, and that's not really a transplant trial, but I wanted to talk about a very exciting new development in cancer treatment. And only very recently has this been approved by the FDA for 2 different indications. There's one kind of indication for lymphoma and one for acute lymphoblastic leukemia. So these are called CAR T cells, and many of you may have heard of them just because of how incredible they've shown in the results as being able to treat relapsed and refractory disease. But basically what they do is they will collect your T cells. So instead of collecting your stem cells like you would do in an autologous transplant, they collect your T cells. They treat those T cells so that they change the genes in them so that they can grow what's called a chimeric antigen receptor, or a CAR. You can see on the left you have a regular cell, and then on the right of it is the CAR T cell with that extra looking appendage. And so what that appendage is it's able to find certain proteins that we know are on some of the cancer cells. So for example, a cancer cell has a protein on it called CD19. So they develop a CAR that can find CD19, and then that allows the CAR T cell to attach to the cancer cell and then destroy it. So it's really exciting what is being done with the CAR T technology, and it's being tested in many, many different kinds of illnesses. So now I'm just going to talk a little bit about our program. It's called the Jason Carter Clinical Trials Program, and it's really designed to help people find trials for blood cancers and blood disorders. And the way it works is we have one-on-one support so that patients or their loved ones can call up and say, hey, I'm looking for a trial, and here's my background, and we can do a search for them and say, well, here's a few trials in your area, and this looks like it might be a good fit. And so we work with them to get in touch with the actual centers to get them joined into the trial. We also have an online search tool which has over 1,100 clinical trials listed in it, and they've been translated into from the language of clinicaltrials.gov, which is quite scientific, to a more palatable and readable format. And then we also have some different resources that can help with education and also financial assistance. This is the search tool I mentioned. So it's U.S. trials, phase 1, 2, and 3, and it's for blood cancers and blood disorders. And it's not just for transplant, but of course transplant is included in that. So it's a little bit broader than the transplant treatments, but we're trying to tackle all of the diseases that can be treated with transplant. This is probably hard to see, but it's just an example. The trial description on the left shows the inclusion-exclusion criteria, which means how can I join this trial? And it's a massive list and very difficult to read. And we're able to kind of whittle away some of those things that aren't necessarily that important to make it easy for someone to say, oh, I think I might be able to join this trial. Let me call them up and see. And we also have a number of different patient resources. We have educational materials that we've built. We also have links to some of the other great organizations that have that information. We just last week finished a video presentation that talks about that CAR T-cell therapy in detail. It's about 8 minutes long, and it's supposed to be comprehensive so that patients can get an idea of what is involved and some of the risks and the benefits of that. So if you go to the Jason Carter website and click on the Resources tab, you'll see the CAR T-cell educational video there. And the last thing that we are offering is a travel assistance grant. So if people are trying to join a trial, but maybe it's out of state or it's not in their hometown, and that's a barrier for some folks, we can provide some funding to pay for airfare and hotel and lodging or food and things like that, so that they're able to actually participate in the trial. Again, our goal is to get as many people into trials as we can, because we know how important that is for both them personally, but also advancing the state of medicine. So in conclusion, we know that sometimes clinical trials are the only option for people when standard treatments have failed to work. And so we need to try to help people get connected to those trials so they have that hope. Participation in clinical trials is essential in order to advance the science of cancer treatment. And in general, cancer patients who participate in clinical trials have better outcomes than those who do not. And I think that's all I have.
Thank you so much, Scott. That was a wonderful presentation, and it certainly makes clinical trials more understandable. I appreciate you being with us today. And I am the last presenter today. My name, again, is Jennifer Gillette, and I am the staff social worker here at the National Bone-Marrow Transplant Link. And it's kind of weird for me to talk too much about myself, but I'll just tell you that I've been in oncology for 20 years, and in that time I've provided counseling, led support groups, educating patients, developing patient programs, assisting with research projects, and led the Fellows Clinic, a place for people to receive cancer treatment who had no insurance when they were in financial crisis. And now here at the NBMT Link, I am available to assist with emotional support, resources, and assist with supportive programs. Now today, I was going to focus on finding ways to cope with the emotional aspects of a transplant journey. And that's just a lovely picture of one of the many people we had been in contact with who made it through the transplant well and is surviving and helping others. But there are multiple research studies documenting the emotional challenges involved with a bone marrow transplant. To start the conversation, I'm showing you a study here from the Biology of Blood and Marrow Transplantation, the official journal of the American Society for Blood and Marrow Transplant. And in 2014, they showed how 31% of bone marrow transplant patients experienced moderate to high levels of depression 6 to 7 weeks post-transplant, even though they'd never even experienced depression before. So this study is just one of many out there that show you, even if you have never had issues dealing with depression in your life, the mere event/process of going through the transplant journey is enough to lead to depression. And in groups I've ran over the years, we've done polls that have surveyed how many people use depression or anxiety medication as they went through a journey, and about 75% of people admitted to using medication. So clearly, research and patient accounts show us that healing from a BMT is more than a physical one. To neglect the emotional trials of this journey is to ignore a major component to your recovery. BMT is a life-changing experience, and it can affect all aspects of your being. So the key here is coping with the cancer or transplant journey is very unique to the individual facing it. There is no magic formula, and healing from a BMT is a marathon, not a sprint, which I have heard from many patients here. Try using some of the suggestions that are shared with you today if you think that they are helpful. But also, again, the key is not to give up finding ways to cope when you are struggling. There are ways to make it through this. My favorite ways to gather this information in coping with the BMT is to ask those who have already walked this path. They are great teachers. So I'm going to introduce you to some of them. Here, this is Lou. He is a dear peer mentor here at the link, and he is an AML survivor of 2 transplants. A man who they believe got cancer from working at ground zero after 9/11 and being subject to breathing in the carcinogens for over a year. He's very inspiring to all of us who know him. And some of the tips that he shared got him through his journey is, one, he had to have the mindset of viewing transplant as a recall to life. He emphasizes the importance of attitude, and he and his wife had the attitude of whatever it takes, we're going to fight this together. He said that was a core thing that he needed to hold on to as he went through this. He also believes in a strong support system, and he said choosing a project to work on for him to distract himself, something that he could do at his own pace and something he could turn to when his mind needed a break from the whole BMT process, was helpful to him. Now, others might say that that's not helpful to them because, you know, there's only so much you can do when you're going through this, but for him it was a coping tool. He also encourages people to be as active as they can. He now, not in the beginning, but he now goes to support groups, senior groups, and stays active. And his wife and he enjoyed walking together and found motivation in an app he called the charitymiles.org, where large corporations will donate to charities of your choice. So that's helped get him moving, and that is some of his strategies for coping. Now here is David, an AML and ALL survivor that has dedicated his life to giving back after transplant to those going through a cancer and transplant journey. He found that stimulating his brain was helpful, so kind of along the same lines as Lou, having something else to think about was something to help him at times. Also looking for positives. Now, that doesn't mean you have to be happy all the time. Some people, you know, feel like everyone just tells them, well, just think of the good things, and that doesn't work every day or every moment. But he did look for positives and found a chance to reprioritize or living life to the fullest. Also, he found that being social was helpful to him. Like, he shares stories about being on the transplant floor and using that as an opportunity to talk to other transplant patients while he was moving. He also emphasized exercise, which is important to note here that we have to learn how to stretch ourselves and keep going. However, it's also a matter of learning not to overdo it, which many of our volunteers that have been through this process have told us. And that's a matter of finding where that sweet spot is. David also told us that one thing that helped him was the online Caring Bridge site. It was a way to journal and inform others how you were doing. And other patients have told me that this can be helpful too when you have multiple people asking you how you're doing and not the energy to get back to them. David also is a huge promoter of having high-quality foods instead of junk food. He volunteers with a program that helps teach nutrition to cancer patients, and this is something that he has said helped him maintain the most he could with energy as well. He also recommends getting involved when you can, and this is something that, you know, you have to wait until you're ready. You know, I recommend waiting at least a year before you go too much into volunteering and helping other people, because you have to get through most of your journey, or at least a big chunk of it, before you can make it better for anybody else. He also recommends accepting life will never be the same. It is different, but the quality of life can increase. David came from a very high-paced corporate lifestyle, and he has opted for a more simplistic lifestyle after transplant. He says that fatigue is no joke, and getting the rest you require helps you get more done. He says it's not uncommon for him to need 12 to 14 hours of sleep a day now, but that he's learned to just accept what his body needs, and it makes everything work better for him in the long run. He also recommends considering counseling, and consider talking with someone who's been through it. We have a really wonderful program here at NBMT Link with our peer mentors, and they can ease fears, give tips, and help you understand more than most people are able to just because they've been through it themselves. Now I'd like to introduce you to Meredith, a spunky mental health professional, an AML survivor, and the founder of the Meredith A. Cowden Foundation, an organization that raises awareness and provides education on the after effects of transplant. Meredith recommends, first of all, the importance of adjusting to the changes in your life. She has shared that discovering the time of day your body is at its peak and trying to schedule what you need to do during this time. So like if you know mornings are really hard for you, making a bunch of appointments in the morning is probably not going to be as easy for you. So doing things like that. She also talks about pacing yourself, allowing yourself breaks, and finding ways to manage the emotional aspects of the journey. So asking yourself those big questions, what kinds of things calm me or bring me peace? What kinds of things help me feel lifted? She also recommends being the author in your life. There are some things in life that are out of our control, but choosing how we respond to it and how we're choosing to have our story go is up to us. And she emphasizes discovering what brings you meaning, joy, and hope. One of the things Meredith hated when she was going through the process was the effect it had on her identity. And she did not want people to see her as a one-dimensional person. She's not a cancer survivor only. She's not a victim. It's easy to be consumed by that constant patient experience. But you are more than a patient, so making sure that you stay rooted in who you are is an important aspect of coping. It's also important to be aware of the new norm for your body. As I had said with David, starting to see what is normal for you after a journey, it takes at least a year to figure out what that might look like. But, there's some people that say it even takes like 5 years to kind of see. So you might continue making gradual improvements, and you need to be patient. Support is another thing that Meredith emphasizes as being very important. She talks about those that are core people in your life and turning to them. And then she recommended the book by Brene Brown that further explains her thoughts on being the author of your own life. And then meet Jen, another AML survivor. She's a human resource professional that had to learn how to navigate the transplant process while still trying to raise a young family. She found it very important to find ways to see growth. It's easy to get discouraged. It's easy to feel stuck. Jen recommends keeping a list of the gains you make so that you have something to reference when those feelings come. She also found it very important to find ways to adapt to her new norm. For example, when she went back to work, modifying her schedule or knowing that she needed to get up and walk around or rest her eyes from the computer periodically, she had to figure out what she could do to perform. She also recommends, which is on our website, the video called The New Normal, produced by the NBMT Link, and it interviews several people that have been through the process, and they go through what helped them get through. Mindset and realistic expectation is also another thing that Jen emphasizes as important. She shares how, and just as I quoted earlier, that this is a marathon, not a sprint when you're trying to recover. So on the note of setting realistic expectations, many survivors talk about finding their new norm. What is this new norm? There will be meltdowns sometimes, and that is okay. It's a long process with gradual improvements, and it's easy to feel frustrated and discouraged. However, try to reclaim areas of importance in your life while allowing for flexibility and creativity. I know there's a really cute story that I have heard about a gentleman who enjoyed making pies and didn't have the energy for it after his transplant. But he found a new way to do that with his spouse by his side. And the parts that he didn't have the energy to do, she did, and they did it together. So seek to find ways to hold on to things that you hold dear. Understand that everyone who loves you walks this journey with you, and you all may cope differently, but work together as a team to support each other. And I'm just going to put a plug in here, too, that caregivers, you need help, too. Caregivers have a lot on their shoulders, so make sure you're getting some TLC. Know when to ask for help, and most people hate doing this, but this is a necessary part during this process. It's also important to communicate with your health team, develop a system to stay organized, or have someone standing by your side with that gift. Communicate clearly with your health team. Try not to be someone who holds back and just tries to tough it out, because the more they know about what's going on with you, the more they can help you. Keep lists of symptoms and questions, and learn how to advocate for yourself. You can have a medical coordinator for your care, copy other healthcare providers on emails, and use the whole team. Don't give up. This journey is long, hard, and can be overwhelming, but find strength and hope wherever you can and follow that recall to life. At this time, we are going to open the floor to questions. It looks like we do have some already logged in here to the computer, so I will start with those, but feel free to keep adding any questions you might have, and I will give them to our presenters. So at this point, as I am looking over here, I want to make sure that we don't do ones that we've already answered, but perhaps I'll give this one to Stacy first. Can you describe life in general terms the first year after transplant?
So what we like to tell our patients, and I'm talking about patients that are getting someone else's stem cells, that it's going to take you 6 months to a year to be back to normal. So if someone is currently working, we tell them plan on being off work 6 months to a year. And we tell them it's not that you're going to be an invalid, you're not going to be like confined to bed, but you are going to be fatigued. Fatigue is number one. Our patients will say how tired they feel, that they may need frequent naps, that they can't do as many things in the day that they used to do. They will need someone to bring them to appointments because we don't want them to drive after transplant initially, because some of their medications are sedating. They can have what we call chemo brain, where they're just not thinking as clear and concise as they used to. So they will need someone to drive. We let them know when they're able to drive again. They will need someone to help them with their meals, someone to help with their housekeeping. So we kind of put it in that perspective, plan that the first 6 months to a year after transplant is going to be a period of readjustment.
Great, thank you. I'll give this one to you too, Stacy. When can the patient go home, and can they be around plants or pets?
So we tell our patients that we want them to be within an hour of our facility, and we bend that a little bit, like if someone's an hour and 15, hour and 20. But if someone's, say, more than an hour and a half away, we do tell them they need to stay close by. We do have hotels that we have discounted rates. Some transplant centers have housing or lodging right on site. Unfortunately, we do not. So we have hotels that give them discounted rates, or they may have a friend or family member that lives within an hour that they can stay with. We say that they need to stay close by for a couple months after transplant. So they're in the hospital for approximately a month. So we like to say, that first 100 days, they need to be within a close distance to our center. As far as plants, if they can put all the plants in one room and then they don't go into that room, we don't want them digging in the dirt. We don't want them caring for plants because there is bacteria and fungus in soil. As far as pets go, we do not tell them they have to get rid of their pets. However, we don't want them cleaning kitty litter boxes. We don't want them picking up dog poop. We don't want them cleaning fish aquariums or bird cages or reptile enclosures, just because various pets can have, carry different bacteria and fungus and diseases. We say if they have a dog or a cat, please don't let them sleep in your bed. Don't bathe them, but they can pet them and play with them, just good hand washing after.
Great, thank you. I'm going to pitch a couple to you, Scott, too. I see one here that says, are there any new effective medications down the pipeline that would eliminate the need for transplants?
Well, I think we talked about the most promising one, which is the CAR T cells. That is showing great promise, but we're just way too early to know for sure. And so transplant is going to be, the best curative option for many diseases for quite some time.
Great, thank you. Also related to the CAR T, there's a patient that's asking, and I'll send this one to you too, Scott, is AML the cancer for a CAR T?
CAR T cells that are approved are for diffuse large B-cell lymphoma, and the other one is acute lymphoblastic leukemia. There are several trials testing CAR T cells designed to treat AML, but those are not yet approved.
Okay, great. Thank you. Stacey, could you answer this one? In preparation of a transplant, what should the patient and donor do to prepare themselves both physically and mentally?
There's no magic thing that we tell them to do. We just say try to stay healthy, try to avoid sick people, which is sometimes hard to do because people go out in public sick. For our patients, exercise as much as possible, eat as well as possible, and for donors, just, same thing. There's no magic vitamins they need to take. It's just, especially when the patient has started their prep, if the donor got sick, that could be an issue, but we don't expect them to live in a bubble, but we just say try to avoid sick people if you can. Stay healthy.
Okay, great. If anyone else has any other questions, you're welcome to send them to us. We can always consult our speakers and get back to you. But for now, I'd like to thank our speakers, our sponsors, our partners, and of course, all of you for joining us today. Just a reminder, we'll be sending out those slides, and we will be inviting you to take a quick survey at the end of the webinar. This will enable us to help future survivors and to continue to develop high-quality programs for those we support. So thank you much, and everyone have a great day.
Thank you. That does conclude today's webinar. You may disconnect your line at this time and have a wonderful day. We thank you for your participation today.